Good evening, everyone. So I think we'll get started. It's 6:05. We have about 133 participants and rising. So we'll just get the ball rolling. So welcome to today's Kenya Society of Anesthesiologists hosted weekly webinar. I'd like to thank you, our audience, for joining us. Today we have delegates tuning in not just from the membership of the host society, but from other specialties and cadres, really spanning the continent, I see. So it is because of you and for you that we congregate. Thank you so much. Our invited speaker, Dr. Idris Chikophe, for taking the time to prepare and deliver today's presentation. Dr. Kaiser Fizwanga for once again contributing to this exchange of knowledge. To the executive committee of the KSA for organizing this series. Our sponsor today, Mindray, for partnering with us, the Kenya Society of Anesthesiologists and all her members and affiliates, Ms. Shelmith Masharia, our society administrator, who truly ensures the smooth running of this forum. Thank you. My name is Angela Ongewe, and I'll be your moderator for this session. I'll ask that we mute our mics and keep our videos off for the duration of the session. And as everyone present today has had to register first, we will not require you to send us your details. So this will free up the chat for questions and comments, and we'll have our speakers address them during the Q&A at the end. So please note that currently there are no CPD tokens for nurses and clinical officers. So we are liaising with your professional bodies to this end. So meanwhile, we'll be offering certificates that will indicate the duration of the session attended, and then these can be used to claim CPD points. These certificates are also being prepared for our delegates who are joining us from outside of Kenya. So we thank you again, and all certificates from previous webinars will be rolled out as soon as possible. And with that, we welcome Dr. Idris Chikophe. He's a consultant, anesthesiologist, and critical care practitioner at the Kenyatta National Hospital, and is the current secretary of the Critical Care Society of Kenya. And in my assessment, he is a visionary and a most charismatic leader. And today he'll be teaching, refreshing, and updating us on intravenous fluid stewardship. So welcome, Dr.
Thank you. Please allow me to share my screen.
Okay. Again, for the audience, we'll ask that you can, if you keep your mics on mute and your videos off. Thank you.
So thank you very much, Dr. Angela, for the kind introduction. So today we're going to talk about intravenous fluids. This is a discussion that we started probably 12 months ago when we did an online survey. You know, we deployed a questionnaire on the various social media platforms where a number of practitioners in Kenya answered questions regarding how well they understand the things that they prescribe on a day-to-day basis, the intravenous fluids. So today's agenda, of course, will introduce the topic, look briefly at body fluid compartments, discuss fluid shifts, the concept of euvolemia and preload responsiveness, and then you look at a few or two of the most commonly used intravenous agents, which is saline and Bringer's lactate. So intravenous fluids are one of the most commonly prescribed agents, whether you're in the operating room, intensive care, or in the emergency department. In fact, nearly 50% of the patients who present to the emergency room with features of a hypoperfusion will get fluid bolus. And in fact, there's a pathologic reflex that has been described amongst practitioners of the OR, intensive care, and the emergency room. that reflex is called the lactobolo reflex. So every time they see high lactate levels, they reflexly give a bolus of intravenous fluid. But you have to understand that fluid is a drug, and the right drug has to be administered to the right patient at the right dose for the right duration of time, after which we de-escalate. Because if given for maybe inappropriate durations or the wrong dose, it has very many side effects. So let's look at the compartments. The total body water basically comprises nearly 60% of the body weight in males. It's less in females, 50%, and it's much less in obesity. And in pediatrics is actually age dependent. 2/3 of this total body water is in the intracellular compartment, while 1/3 is in the extracellular compartment. So this is an example of a physiologic male who is weighing 70 kilograms, who is very lean. So their expected total body water will be 42 liters. Of course, 14 will be in the extracellular compartment, and 28 will be in the intracellular compartment. 3.5 liters will be in the plasma, and the rest will be in the interstitium or in some other parts of the body, the transcellular fluids. So in pediatrics, the total body water is actually dependent on the body weight, which is basically an age-dependent parameter. So when they're newly born, their total body water may be as high as 90%. And as they gain weight or they grow, you find that the proportion of the weight that is contributed by total body water reduces, so that by their maybe 30 kilograms, they're almost near the adult physiology. And in pediatrics, the factor of gender is not very, very important in determining the total body water. So for us to say that the internal environment is well taken care of, we have to have our fluid, the volume has to be appropriate, and even the components, what you call the number of osmotically active particles in that volume has to be sort of controlled within a narrow physiologic range. So on average, we have an osmolality of around 280 milliosmoles per kilogram. So this is the number of osmotically active molecules per kilo of water, all right? So in a physiologic man of 42 liters, we have the 14 liters, giving you a total number of osmoles of 3,900. And in the intracellular fluid, we have almost 8,000 milliosmoles, making a total of nearly 12,000 milliosmoles. This is very, very important because when you look at the Darrow-Yannet diagram, it helps us define what we call the fluid shifts. So we've always had people talking about fluid shifts, but we have never really thought about it. But there are a few principles that need to be observed when we're trying to understand fluid shifts. So the first principle is that water gain or loss primarily happens from the extracellular fluid. Once you lose the fluid, it leads to perturbations in your osmolality. And the change in the osmolality is the one that governs the movement of fluid, either from your extracellular fluid into your intracellular fluid, or from your intracellular fluid back to the extracellular fluid. And you have to understand that water moves from a region of a lower solute concentration to that of a higher solute concentration. And this water movement, or what we call fluid shift, stops when both the intracellular and extracellular osmolality are equilibrated. So look, for example, at this Darrow-Yannet diagram, whereby this patient has lost free water, for example. So what happens is that they lose free water from the extracellular compartment. Then the extracellular fluid osmolality increases. So that therefore means that water will actually shift from the extracellular from the intracellular compartment to the extracellular compartment. And we end up having a lower total body water, a decrease in both intracellular and extracellular fluid compartment, and an increase in both in osmolality in both compartments. So this is what happens when you have, you know, free water loss. A problem like adrenal insufficiency, for example, where you are losing lots of osmotically active particles like sodium, of course, we'll end up losing the osmolality initially. Of course, there's gonna be also reduced, increased loss of fluid, but the loss in sodium is more than the fluid loss. So you end up with a reduction in your extracellular fluid volume. Also, you end up with a reduction in your extracellular osmolality. And then there's gonna be an increase in your intracellular fluid, which further reduces your intracellular osmolality. So this is the fluid shift that happens in adrenal insufficiency. And in diarrhea, you're basically losing a volume that has, you know, a good, osmolality that is equal to your plasma. So it's iso-osmolar loss. The fluid that you're losing is iso-osmolar. And what happens is that the osmolality in your extracellular compartment does not change. So there won't be any fluid shift. So when you have osmotic dehydration, iso-osmotic dehydration, you basically lose your extracellular fluid compartment and nothing happens to your intracellular fluid compartment. When you have a problem like a syndrome of inappropriate secretion of your antidiuretic hormone, it means there's increased free water reabsorption, which increases your extracellular fluid volume, which will reduce your extracellular fluid osmolality. And this will increase the movement of water from the extracellular into the intracellular fluid compartment, which further leads to a reduction in your intracellular osmolality. So basically that is what we mean by fluid shifts. And there are very many scenarios. This just are, I've just picked a few of those many syndromes that may lead to what you call fluid shifts. Syndrome of inappropriate antidiuretic hormone production is really, really common, especially in the perioperative states, in the intensive care unit. And for example, if you give fluids that are very hypotonic, then you may get, it may exacerbate your water retention. So we have this case of a 28-year-old diabetic who presents with nausea, vomiting, and abdominal pain with orthostatic changes. So when they sit up from, let's say, a supine position, they get either tachycardia or hypotension. So his current weight is 60 kilos, and his laboratory shows a sodium of 146 millimoles per liter, potassium of 5 millimoles per liter, bicarbonate of 10, urea of 70 milligrams per deciliter, and glucose of 540. So you are either able to measure the osmolality using an osmometer, depending on where you practice, but majority of us don't have that device, so we actually calculate the osmolality by multiplying the sodium by 2, and then adding the urea and the glucose. So basically, when you do the maths, it comes to around 347 milliosmoles per kilogram of water. But you realize that urea is not an effective osmol. So it may not contribute to fluid shift. So we talk of tonicity then. Then tonicity will be the sum of sodium and blood glucose. This is the one that will lead to fluid shifts. So for example, given that the effective osmolality is 322, if you give this patient 1 liter of water, this patient was 60 kilos, so his total body weight is 36. If you multiply that by his current osmolality, and then you're giving him 1 liter of saline. 1 liter of saline has an osmolality of 308. So you add this, and the total body fluid will have increased from 36 to 37. Then the overall osmolality will marginally come down to 321.6 milliosmoles per kg. Same for Ringer's lactate. It slightly reduces your osmolality. But when you give 1 liter of free water, for example, you find that the osmolality, total osmolality reduces to around 313. So basically you see the effect of adding various fluids to the intravascular compartment. So that therefore means that when you add saline, it doesn't change the osmolality so much. So there won't be movement of fluid into the intracellular compartment. You find that the original intracellular fluid compartment was 24, which is 2/3 of your 36. And when you add 1 liter of saline, it barely improves. Also, when you add 1 liter of Ringer's lactate, marginal improvement. But when you add free water, the fluid volume actually increases from 24 to 24.7. So that therefore means that hypertonic fluids will sort of work on the intracellular compartment, while isotonic fluids will tend to remain in the extracellular compartment. So you find that here, the original extracellular fluid was 12 liters. With saline, it increases to 13 liters. With Ringer's lactate, it increases to 12.9. And with 5% dextrose, it only goes up by 0.3 liters. So the interstitial compartment will increase by 750 mLs when you give normal saline. It will increase by maybe 675 when you give Ringer's lactate. It will only increase by maybe 2.25 or 225 mLs. Look at the intravascular compartment. When you give saline, it increases by 250, maybe 225 for Ringer's lactate, but when you give 5% dextrose, which is basically free water, it only increases by 75 mLs. So this is the distribution of, volume of distribution of isotonic fluid. You find that the interstitial fluid compartment benefits more. The intravascular compartment sort of gets 1/4 of what the fluids, of all the fluid that has been given, while the intracellular part does not benefit at all. When you give hypotonic solution, you find that it is the intracellular compartment that benefits the most, nearly 700 mLs. You have around 225 in the interstitium and less than 100 in your intravenous compartment. So these are the crystalloids that we use the most. So when you're using isotonic fluid, it will be very useful in when you have extracellular volume depletion. Hypotonic, you may improve both intracellular and extracellular, but the intracellular part benefits more. Hypertonic, you use it when you have, for example, symptomatic hyponatremia. So these are the common fluids that you give. We have saline, which has an osmolality of 308, while it is in the bottle, but once it's infused in your body, your total osmolality reduces to around 287. There's an osmolality coefficient. So you multiply 308 by something called an osmolality coefficient, which is around 0.9, which gives you an effective osmolality of around 287. And that's why we say normal saline is isotonic to your plasma. 5% dextrose has high osmolality when it is outside, but as soon as it checks into your body, all this dextrose will be metabolized. And you get this kind of osmolality because 5% dextrose has the same sodium and chloride content as saline, 0.9% saline. The other fluid that you give most commonly in our operating room is a Ringer's lactate, which has an osmolality of around 272. So 5% dextrose is very important, and you want to replace water deficit in hyponatremia in a patient who does not have orthostatic changes. So you want someone who has hyponatremia, but they're sort of euvolemic. Sorry, this is supposed to be hyponatremia, not hyponatremia. It's also useful in that it provides energy and prevents starvation ketosis. And it can be mixed with the other agents like amino acids when you're administering total parenteral nutrition. It is not a good idea to give it when you suspect a syndrome of inappropriate secretion of antidiuretic hormone. And it's not useful in hypovolemia because it is not an intravascular compartment expander. Like you've seen, it's only the intracellular fluid compartment that benefits from giving hypertonic solution. 0.9% saline Of course, it's useful in hypovolemia with orthostatic changes. And you can also give it even in the setting of hypernatremia. It doesn't like really increase your sodium concentration. It in fact will dilute, because at some point when you have a patient who has a sodium level of around 160 millimoles per liter, you do their total osmolality, it may actually be way above 340 milliosmoles per kg. So when you give 0.9% saline, which has an osmolality of 3.8, I mean of 308, the saline is actually hyperosmolar compared to your plasma at this point in time. Saline is useful in saline responsive metabolic alkalosis. These are patients who have hypochloremic metabolic alkalosis, like the kids who are in persistent vomiting because of pyloric stenosis, pregnant ladies who are suffering from hyperemesis. And once you put an NG tube and you leave it draining, they lose lots of hydrogen and chloride. So they go into hypochloremic metabolic alkalosis, and saline may be a useful drug. I have seen it being used as a fluid of choice when you're preparing your patients for contrast studies. Ringer's lactate is useful in burns and surgery because it's a balanced salt solution. It's sort of, it has a lower chloride content compared to that of plasma. And you know, chloride is actually being implicated with lots of adverse effects from fluid infusion. So the hyperchloremic metabolic acidosis is very bad. The chloride has also been associated with renal vasospasm. And in some studies, there's actually been increased risk of maybe acute kidney perturbations when you use solutions that have very high chloride content. So Ringer's lactate, because of its low chloride content, may be a better solution for most of the day-to-day indications, especially in the operating room, and also as a maintenance fluid in the intensive care unit. The fact that the Ringer's lactate has a pH of 6.8 when it is in the bottle, but once it's infused into the body, you find that that lactate is actually metabolized into bicarbonate, which further increases the pH. And therefore, Ringer's lactate is an alkalinizing solution and may be useful in metabolic acidosis. You find that the potassium constant in Ringer's lactate is 4 millimoles per liter. I would give it even when there's a bit of hyperkalemia, because you find that the increase in pH from Ringer's lactate may actually cause intracellular shift of your potassium. Actually, normal saline may be worse in hyperkalemic state because the pH reduction from normal saline may actually cause significant extracellular shift of potassium. Ringer's lactate does not potentiate lactic acidosis, but I will use it with caution when there's liver disease. So there's the concept of euvolemia and fluid responsiveness. Euvolemia has been described as a state of fluid volume that allows adequate filling of the heart and the blood vessels. And this ensures that there's good enough cardiac output to match oxygen demands of the body. And you remember the oxygen delivery equation, which takes into account of your cardiac output, your hemoglobin. This is the Hufner's constant, which tells you how much oxygen, how much volume of oxygen is carried by 1 unit of hemoglobin per deciliter of blood. And this is your arterial oxygen saturation. So you find that the cardiac output is very, very important. The hemoglobin is very, very important. And of course, increasing your FiO2 when patients are having hypoxemia is very, very important in increasing your systemic oxygen delivery. So we can augment cardiac output by giving fluid of the various types. It can also be blood transfusion. Blood is the type of fluid to just increase your carrying capacity. So therefore, fluid responsiveness is actually the ability to demonstrate a 10 to 15 increase in your stroke volume or cardiac output or cardiac index upon fluid challenge. Cardiac index is your cardiac output divided by your total body surface area. It's supposed to range between 2.2 to 4 liters per meter squared. And in various studies, it's been shown that 50% of all hemodynamically unstable patients may be fluid responsive. Therefore, it means we need some form of guidance, especially for patients who are not straightforward. When the patient comes in with a bleeding, artery, for sure they are hypovolemic, and large amounts of fluid may actually save this patient. But there are those patients who are neither here nor there, because when you look at the classification of shock, we talk of cardiogenic shock, we talk of hypovolemic shock, and we talk of distributive shock, but sometimes some of these classes are sort of artificial because the pathology tends to be overlapping. So sometimes you cannot really tell whether this is hypovolemic or it's septic or it's cardiogenic. Look at a septic patient, for example. Of course, they have the vasodilatory shock because of what they're already having, but this patient may not also be eating or drinking. So they may be relatively or even absolutely in hypovolemic states. And much later, when the sepsis progresses, some of those, the cytokines are direct myocardial depressants. So you find that the classification is actually more of artificial. There's quite a bit of overlap. So these patients, you may not be able to tell for real whether they need fluid or they need something else, or they need fluid and something else in combination. All right. And various talks have been said regarding the status of your volume. So volemia is where your body is. Euvolemia is the happiest point, okay? And this is the point that is associated with minimum adverse effect, because when you're dry, then you hypoperfuse every vascular bed, and you can go into multi-organ dysfunction, hypertension, you can go into renal failure, and you can go into, cardiac dysfunction. When you give too much fluid, you can get lots of ileus and enterofluid intolerance, for example, for those surgical patients. You can get pulmonary edema, you can get cardiac dysfunction, you can get edema of maybe your skin and connective tissue, and you can get an increase in maybe surgical site infections. So I think we have to try and achieve what you call euvolemia. But you realize that patients are not the same. I remember the days when we started working in medicine and you're doing maybe cesarean sections, we would pre-write the notes that this patient needs 3 liters in 24 hours. So the notes are already pre-written, but you realize that some patients were small, some patients were bigger, some patients had a higher fat content. So the thing of writing 3 liters in 24 hours is not precision kind of medicine, because various patients are at different levels, and the euvolemia tends to be different for each patient. And we have to try as much as possible to determine the best point for each individual. So I'd like you to look at this video. It is a patient who's being monitored in the intensive care unit. You look at your ECG, you look at your invasive arterial tracing, you look at your central venous pressure, and this is your central venous saturation. This patient seems to be a bit stable, but as time goes, you find that there are changes that are happening. You find that your central venous saturation is actually going down. Your heart rate is relatively stable. Your blood pressure is also relatively stable. Your CVP, I think, is coming down, but you can see that the changes in your central venous saturation are preceding these changes in your macrovascular parameters. So by the time, the management of fluid is actually dependent on so many factors. Some factors are actually preemptive, like the central venous saturation, because it detects oxygen supply demand imbalance way earlier than these other macrocirculatory parameters like the heart rate. By the time you're seeing a drop in your blood pressure, it's probably too late. By the time you're seeing a drop in your central venous saturation, this patient is really, really sick. So like I'd say, the best method of monitoring this patient is multimodal. Some parameters help you to, preempt the change in hemodynamics or the change at a cellular level. And some parameters actually are a bit too late. So the advice is for us to be looking for some of these parameters for those patients that maybe difficult. The patients are not straightforward, okay? And once we suspect that there is need for volume, we can confirm that by you looking at these dynamic indices. Like one of the most commonly used is the, either stroke volume variation or pulse pressure variation. The principle is the same. It's based on the cardiopulmonary interaction. So you have cyclic changes in your inferior vena cava, which leads to cyclic changes in your right ventricular outflow, which leads to cyclic changes in your aortic blood flow. So for example, if you look at this patient, they're basically on the ascending limb of your Frank-Starling curve. The Frank-Starling curve is, it tells us that you may be able to augment your stroke volume in mLs per beat when you increase your venous return until a point whereby a further increase in your stroke volume may not really necessarily lead to an increase in your stroke volume. So for example, this is a patient who probably will benefit from fluid bolus, and he'll get the bolus, and you can see it has shifted from the ascending. It's approaching the near flat portion, and additional boluses are being given. So the patient has actually changed from red to green. It means the cardiac output has been optimized. But sometimes we give these patients exogenous fluid boluses. And you have seen those of us who practice cardiac anesthesia, you get this patient who has maybe core pulmonale, and then the heart is already full. So even the induction drugs, if you want to do maybe adenoid surgery, the little propofol and maybe muscle relaxant is already good enough to take this patient from this, ascending portion to the flat portion. So sometimes you may want to give an endogenous bolus so that if the patient reacts adversely to it, it may be very easy to sort of reverse this kind of therapy. So one of the things that you use the most, one of the things that is useful is actually the passive leg raising test, whereby if a patient is sort of semi-recumbent, they are forced to lie on their back and their legs are lifted, and then you sort of auto-transfuse yourself with a bolus of around 4 mL per kilogram body weight. So for example, if we do the passive leg raise test, you find that this patient will auto-transfuse themselves and there'll be an increase in the cardiac output. But if this patient does not tolerate this increase in cardiac output, you just lower their legs and the volume redistributes. And if this patient becomes congested, you can just sort of reverse this congestion. So there are various ways of trying to assess the need for fluid bolus, especially for patients who are not straightforward, because just giving a fluid bolus outright may actually be detrimental. So sometimes you have to try and predict before you do the actual thing. And we have been focusing mostly on the Frank-Starling curve, but you realize that the Frank-Starling curve actually talks about the forward flow, what comes out of your left ventricle. But is that force the same force that gives you your venous return? I'm not really sure, but there's also been the description of the Guyton venous return curve. So you look at this diagram over here. This is your, what you call the mean filling pressure, which is your venous pressure tone. And this is your venous return on the y-axis. So for example, you can look at your baseline cardiac function, okay? At this point in time, where sorry, somebody is making noise. Hello, please mute your devices. So you look at this cardiac function, it is not really optimum. Something maybe can be done, all right? So at this point in time, you find that the cardiac output is probably suboptimal and your venous return is not maximum, okay? But when the patient takes, let's say, a deep breath, they may lower their right atrial pressure and they increase the hydrostatic pressure gradient to increase your venous return. So with that lowering in your right atrial pressure, you actually may increase or augment your venous return and sort of push your cardiac output from this curve A to curve B, you know. So just maybe reducing your right atrial pressure, you may actually augment your venous return. And that's what happens when patients are breathing spontaneously. Sometimes that may not be possible in the setting of reduced vascular tone. And you may have to maybe use something like a vasoconstrictor to sort of increase the venous tone, to increase your venous return, and hopefully improve your cardiac output. So you can find over here in a patient who, let's say, has vasodilatation, you find that the venous return is sort of reduced and your cardiac output is really, really minimized. But the application, let's say, of a tonic agent may actually push the cardiac output from this limb, from this curve to that curve. And this therefore leads us to what we call the decision support systems that we need to have in our intensive care units or in the operating rooms. So this is a goal-directed sort of decision support system where we have a patient who presents, let's say, with low cardiac index. So the cardiac index is less than 2.2. And when you look at their pulse pressure variation, it's more than 24. So they can actually benefit from a fluid bolus, and they move from this quadrant, which is basically a hypoperfusion state. When they get a bolus, they actually move straight to the target zone, which is the sweet spot. And this is a patient who is purely hypovolemic. But sometimes you may give one fluid bolus, then they move to this spot, but the cardiac output is barely going above the safe zone of 2.2. So if you give more fluid boluses, then again, you remain low in terms of your cardiac index, but you find that your heart filling pressures are really high. So this may be the time to maybe, give cardiotonic agents. But actually, use of these decision support systems have been shown to increase the early use of cardiotonic agents like vasopressors and inotropes. Sometimes the patient comes already, very full, and they may need either diuretics or vasodilators. So you find that when you have a decision support system, it actually may help you decide whether fluid is more important, fluid alone is important or adequate, or fluid and early, infusion of vasopressors and inotropes. And in fact, it's been shown that early use, like if you start your vasopressors or inotropes to a patient who needs it, if you start it in the emergency room, by the time they're getting to the intensive care unit, they may be better placed as compared to when they have delayed, infusion of vasopressor agents, if that patient needs it. All right. So this therefore leads us to a concept called the ROSE concept. So patients who come with features of hypoperfusion, of course, they get lots of fluid, all right? In the first few minutes, they get multiple fluid boluses because we want to address the deficits. We may want to address ongoing fluid losses. We may also want to get the maintenance for the day. So this is what you call the resuscitation phase. There's a lot of fluid. And maybe this patient already has a bit of kidney dysfunction. They're already in renal debt. And at the end of the maybe 24 hours, you find that this patient is in significant positive fluid balance, okay? But maybe that was necessary because we weren't so sure of whether this patient benefited from fluid alone or they needed vasopressors, because most of our emergency rooms may not be in a position to tell us exactly what needs to be done. But this is the point where the patient is in decompensated shock. If you sort it out, then they go to the optimum phase where the patient has moved out of the decompensated shock to a compensated shock. So at this point, you may be giving them a baseline infusion of fluid, but when your predictors for fluid responsiveness allow, you give them additional boluses. So the first phase where you're doing rescue therapy, that is bad, and we call it the first hit. When you move to your optimum phase, you're basically in a phase where you're likely to suffer what you call reperfusion syndrome. And this patient is at risk of getting what you call polycompartment syndrome. So they may get abdominal compartment syndrome, which of course has, problems with your chest, with your kidney and everything. So you get multi-compartment syndrome and reperfusion injury. But patients may actually recover. Most patients do recover, and you go into the stable phase where your nutritional needs your fluid only meets your nutritional needs, all right? So this is your first hit. This is your second hit. That's the optimum phase. So you hope that this patient actually improves. We hope that by day 5, your patient is in stabilization phase. And this patient is actually not gaining weight from too much fluid, because there's that concept called the cumulative fluid balance. Every day of your patient's intensive care stay, the patient accumulates additional fluid. So for example, you say you want 3 liters in 24 hours. So you give the 3 liters, but the patient only produces urine, maybe over 1,000 cc's. So by tomorrow morning, they are positive 2,000 cc's. We talk of insensible water losses, but sometimes it's neither here nor there. In ICU patients, they may have lots of like the seared, and they may be accumulating a lot of fluid. And sometimes we also tend to give lots of hypertonic fluids. So, the density of water is 1. With every gram of water that you retain, you add a gram. So that if you are admitted with a weight of 70 kilos and your weight gain goes to 77, you have added another 7 kilos, which gives you an additional 10% of your baseline or your admitting weight, then you are already in significant positive fluid balance. And this is a point where it may be associated with major adverse effects. We hope that after this point, maybe after the 3rd or 5th day in intensive care, you find that maybe your endothelium has reintegrated, your oncotic pressure has come up, and you evacuate your own fluid spontaneously. So you go into the evacuation phase. But sometimes this doesn't happen. We give the patients a tertiary hit or a 3rd hit by contaminating them. So we give them hospital-acquired infections, and they go into what you call the capillary leak syndrome. So they continue, accumulating fluid, and you may have to get the services of a nephrologist to do some sort of hemofiltration, or sometimes you use high-dose Lasix with a PEEP and albumin, okay? Just to make sure that this patient goes to some sort of negative fluid balance. And when the patient is here, they have achieved a good evacuation, their body weight has reduced, they're in negative or neutral fluid balance, maybe this is the time they can be extubated from the intensive. They can be extubated. So there are a few trials which look at the type of fluids that we give. There's a split trial which was done in 2015, where it was comparing saline and plasma-lyte. Plasma-lyte is a form of a balanced salt solution. And these two groups were getting a medium volume of around 200 cc's, and they did not report a difference in the acute kidney injury or need for renal replacement therapy or mortality. But some limitation in that. In the split trial, they were looking at mostly postoperative population. They had low disease severity, and they did not delineate between resuscitation and maintenance fluid, all right? They went to the SALT trial, where they're looking at saline and balanced solutions. The SALT group were getting around 1,400 cc's. The other group of balanced solution were getting around 1,600 cc. The saline group had a higher chloride content, but they did not realize any difference in terms of acute kidney injury or the need for renal replacement therapy, or what you call major acute kidney, major adverse kidney events. There's a SALTED trial which was conducted in 2018. This one was looking at non-critically ill patients who are again getting 0.9% saline and balanced salt solution, and there was a significant increase in the major adverse kidney events at 30 days. And I think the last trial I would like to discuss is the SMART trial. This one was looking at critically ill patients in various ICUs, multi-center, and they were using saline and balanced salt solution. Of course, the balanced salt solution had significantly reduced major adverse kidney events at day 30. So what am I saying? That we need to choose the right patient in terms of biochemistry and volume, because these are the very important parameters that determine how the fluid shift is happening. You need to choose the right fluid. You have to give it using the right mode of administration. Of course, for those who are acutely ill, they may benefit from intravenous fluid therapy, but once they stabilize, maybe you transition to enteral modes of feeding. Enteral mode of fluid administration. You have to give the right dose for the right duration, after which we need to de-escalate, or what you call de-resuscitation. I think that's the end of my presentation. Thank you very much.
Thank you very much, Dr. Chikophe. Thank you. This was a most enlightening presentation. I was clearly, personally, way overdue for this, and I can see that it's already generating quite some discussion. But before we go to that, the Q&A, and I'll introduce your co-speaker for that, who will be tackling those questions. I will first introduce our sponsor today. Let us welcome Mr. Ayub. He's the application manager for French-speaking Africa, speaking on behalf of Mindray, to tell us about their products. Welcome, Mr. Ayub. Mr. Ayub, are you with us? Can you hear us? Sorry, we're just waiting for Mr. Ayub to share his screen. Mr. Ayub, are you online? As we wait for him to come, I'll ask that you continue to post your questions on the chat. Dr. Fitzwanga, I'll preempt and is handling some of those questions, but we'll still talk about them just in case any of us have missed them.
Ladies and gentlemen, lovely to see
Thank
you
you
today. First of all, I would like to thank KSA Association and our partner Crown Healthcare for organizing this webinar. And special thanks to Dr. Idris for this very interesting presentations. We get a lot of information from you, doctors. Thank you very much. Let me introduce myself. My name is Ayub. I'm a product specialist for patient monitor life support. And I'm very glad today to have this opportunity to share with you some interesting features we have in Mindray patient monitors related to hemodynamic assessment and fluid management. So let's start from the basic. So what patient monitors can do? So as you know, all the patient monitors are just equipment to reflect the vital signs. So at the most, we can provide some advanced parameters such as cardiac output, such as the EEG, and etc. But beside of all these parameters, our clinicians still face a lot of challenges to make the right decisions in some critical care situations. This is why Mindray tried to design the new concept called clinical assistive applications. This clinical assistive applications is like a clinical app that we can upgrade in our patient monitors, especially our high-end patient monitors, Benevision and Series. And the aims of this clinical applications is trying to reduce the workflow of doctors, trying to have the doctors to have fast and right decision. So how we can do this, I will explain later. And also trying to convert all the huge data coming from the patient monitors into very useful informations. So today we will try to focus on one of these clinical applications called Hemocyte. It's designed for circulatory system. And we will discuss deeply about the real benefits behind these applications. So when we use the hemodynamic monitoring generally with the PICO module or any other external devices like a VGLU, or we use SCVO2. So the main problem, the main challenges that we face is a lot of variables. So you are overloaded by informations, and the challenge is to take right and fast decisions. This is the first challenge. The second challenge is how we can find out the problems of our patients and try to trace the causes. So hemocytes, or our clinical assistive applications, hemocyte is the solution of these challenges. So it will support our doctors from monitoring to diagnosis, to test, follow-up, and even evaluations. So let's start from the first part, diagnosis. So if you remember, the first challenge we have when we use hemodynamic monitoring is a lot of parameters. So if you see here, all the hemodynamic parameters are well arranged by grouping display. So we see all the parameters related to output, all the parameters related to contractility, all the parameters related to preload volumes. And also we have we show even in some parameters the normal range of each parameter. So if one of the parameters is out of the range, it will show us that is out of the range. So well organized parameters related to or each group. And these parameters for sure can be printed out and use it as reports, okay? So, but till now we didn't answer the questions of how we can make useful these informations, these complicated informations. We have what we call physiology graphics. It's a hemocytes graph. So it's a smart and intuitive way to show all the complicated hemodynamic parameters. And if you look at here, it shows the interactions between the heart and the lungs. Here is the right heart, here is the left ring, left heart. So if you see here, we can even show the contractility, we can even see the preload. So if you look at here, for example, this is the systolic phase, right? So if you check this part, the contractility, the dash line is the normal range. So if it's beyond the dash line, means that we have insufficient outputs, you have a low contractility. So this is for normal contractility, and this is for low blood remain. Okay, so we can even show just by seeing the physiology graphic the problem of contractility. Okay, so not only the contractility, but also we can see the preload. So global and diastolic index. If you see here in diastolic phases, here, if it's beyond the normal, means that we have a high end diastolic volume, high preload. This is for normal preload, and this is for low preload. So all these complicated informations can be just seen easily by a smart pictures, which can show the contractility, the preload, not only this, even the resistance here. So if the resistance is high, you will see that the vessels are too tight. So this is for normal, and this is for low resistance. The colors change depends on the SpO2 values and SCVO2 values. We can even monitor the extravascular lung water. This is the normal limits, and see if it's rising or falling. So all now these complicated informations, we try to convert it into very useful informations by physiology graphics. So now the second challenge is how we can find out the problem of our patients and trace the causes. So here we have what we call physiology relationship. So if SCVO2 is, for example, out of the range, 68, so means that we need to check these two parameters, maybe the oxygen consumptions or the oxygen delivery. Okay, so the green frame means that the oxygen consumption is in the normal range. So we need to check the red frame. The red frame indicates that the value is beyond the normal range. So we need to check the oxygen delivery. We know all, according to the presentation of Dr. Idris, the oxygen delivery depends on hemoglobin, oxygenations, and cardiac output. So his is in the normal range, so we need to check the continuous cardiac index. The continuous cardiac index depends on the stroke volume and the heart rate, and then the stroke volume also depends on contractility, resistance, and the preload. So you see here you can trace all the causes, and trace all the causes. The full line indicates the direct relationship, and for sure the dashed line indicate indirect relationship. For example, extravascular lung water, if it's high, for sure, it will affect the oxygenation and the SpO2 will decrease. And finally, just for the first step, the decision models, we have the decision models derived from Polshin to guide us to choose the right treatment for the patient. So this is the measured values, and this is the target. So, and here we will highlight and display the treatment paths according to the patient situations. Now let's switch to the second step, is the test. So we know that the fluid resuscitation is one of the major treatments in hemodynamic therapy. So if you have an accurate fluid resuscitation, it will increase the stroke volume for sure, and it will increase also the tissue perfusion and improve the heart, improve the lung function, improve the organ functions. And if you have improper fluid resuscitation, for sure, it will have a lot of problems like a pulmonary edema, like respiratory failures, like prolonged mechanical ventilation. So this is why we need to have an assessment, an accurate assessment for patient fluid responsiveness to avoid any unnecessary fluid resuscitation. So with Mindray, with hemocytes, we can support our doctors to do even the tests. We have two tests, and we can even customize other tests like a passive flag raising and rapid fluid lowering. So the passive flag raising, we know this. So we raise the leg of the patient are raised, causing the gravity to pull the blood from the legs, and for sure it will increase the hemodynamic parameters. So how we can work with these tests in our application? For example, if you want to start the passive leg raising, you just check the input, the test duration, and choose the test and starts. So after you finish the test duration, for sure, you will compare the references of all the hemodynamic parameters with the current value of hemodynamic parameters, and for sure you will see the changements from the references and current value. The same thing with rapid fluid loading. Also, we give to the patient an intravenous injection of a certain amount of liquid, roughly an hour, half hour, and then we observe the change of hemodynamic parameters. So we can even customize our own test and see if these parameters change or not. So at the end, we can print our test results. So the third step is the follow-up. So with hemocyte also, we can support our doctors during the follow-up. So using heart function curves. Heart function curves is like a guidance during the treatment, during the hemodynamic treatment. So it's based on Frank-Starling mechanism. And Frank-Starling mechanism, you know all that when the stroke volume increase in response to increase the preload. So here, for example, is the current situation of the patients. The heart function point is here. So if we increase, for sure, increase the fluid resuscitation, the stroke volume will be increased because it's in the rising section, okay? So, but if we reach the B here, and we want to increase the fluid resuscitation, the stroke volume will not be increased. So what we should do, we need at least to add some positive inotropics to rise this curve and to reach the target treatment. This is the target zone. So this is the target treatment that we want to reach this target zone, okay? So this is how it's work during the follow-up with the Frank-Sterling mechanism. And you know, the general idea is trying to adjust the fluid first before to add any positive inotropic. So here with hemocytes application, if you look at, you have a continuous cardiac index and you have the preload. This is the target zone, and you will adjust for sure your fluids depends on this target zone. By the end, and to finalize for sure, we make evaluations. So we just compare what we have as a references, the references, all the hemodynamic values that we already measure in the beginning, and with the current values. And for sure, we will see if our treatment was good or not. So we can make an evaluations. So the white ring represents the reference values here, and the green ring represent the current values. So if it's, for example, yellow means one of these parameters is out of the range. If it's, for example, red ring means that one of these parameters, one or two of these parameters is out of the range. So we make evaluation of all the hemodynamic parameters according to the references, current value according to the references. And at the end, for sure, we have a trend of all these parameters. So with the current values and the references, and also all the trend from the beginning to the end. So to evaluate our treatment. So this is the end of my presentation. I think that I share a little bit some interesting features in our hemocyte. Thank you very much.
Thank you, Mr. Ayub. Thank you very much for that presentation. I think the hemocyte application really does present quite high-level integration of data, and the interface and the visual is also quite impressive. I think in trained hands, that looks like quite something that we would have in our armamentarium. For anyone who has questions further or wants to perhaps contact you, we shall share those contacts. Thank you very much. We really appreciate that. Very enlightening. And it gels very well with the presentation we just had. So we're going to open up the Q&A session now. And just for then, we'll continue Dr. Chikophe, but we also welcome Dr. Kaiser Fizwanga. She consults part-time as a pediatric intensivist at the MP Shah Hospital Pediatric Intensive Care Unit, and is involved in the aeromedical transport of critically ill patients with AMREF flying doctors. And she's very dear to us. She's heavily involved with our sister body, the Critical Care Society of Kenya, and she's been on this forum before, and we will continue to invite her. Welcome, Dr. Fitzwanga. So as she logs on, or she turns on her mic, I'll ask the two of you to unmute yourselves. There are some questions coming into the chat. Dr. Chikophe, your presentation has really been wonderfully received, and there are questions coming in. Some of them have already been answered, but I'll still bring them out to this forum. Fiona Kahonge was asking you to expound on why you exercise caution with Ringer's lactate in liver disease. Dr. Fitzwanga had answered that, and maybe I'll let you say it again for those who didn't catch the answer.
Of course, can you hear me?
Okay.
Hello?
Dr. Chikophe, we can hear you, but we can't hear your co-host. Dr. Fitzwanga? I think you can go ahead.
Hear me?
Okay. We can hear you, but it's a bit in and out.
Okay.
Oh, there's the theoretical fear. Are we talking at the same time? Hello? Hello?
Okay, you can go ahead, Dr. Chikophe. I think just go ahead, and then we'll catch up for the next question.
So there's a theoretical fear of maybe lactic acidosis, but it's really, really theoretical, if I may say, in liver disease, because the liver is the one that sort of deals with the lactate in the body. So,
Okay.
yeah, it converts, lactate to sugar through the Cori cycle. So if you give huge volumes, there is that theoretical fear of getting hyperlactatemia.
Okay.
But it is more theoretical than practical.
Okay, thank you. Okay, I'll go direct to the next question. Dr. Fitzwanga, when you are able to join us, please go ahead. But in a patient with hemorrhagic shock, at what point of fluid resuscitation would you be worried about dilutional coagulopathy, assuming blood has not arrived? This is from Cyril Sanya. I think, Doc, you'll just go ahead until Dr. Fitzwanga can join us.
I think Fitzwanga
Can you hear me?
Oh, we can hear you now.
All right. Okay. Thank you very much.
Thank you.
So, I mean, where you have hypovolemia for any sort of loss, you should give fluids. It's prudent to give fluids. However, if it's due to blood loss, you must give blood. And if your blood hasn't arrived already, if you're requiring, remember in trauma patients, the fast clot is the best. So you want to be a bit more judicious and not give, your 20 per kg fluid boluses because of fear of dislodging the fast clot. It is prudent to actually bring in tranexamic acid for purposes of hemostasis. However, if you're using blood products, there's a concept called massive hemorrhage, okay? So if you're requiring the definition of massive transfusion, if you're requiring more than 4 units in an hour, or in pediatrics, if you're requiring 50% of their blood volume in 3 hours, or 100% of their blood volume in 24 hours. For adults, if you're requiring more than 10 units in 24 hours. This, if you're just giving packed cells, you're more likely to cause dilutional coagulopathy. So it is prudent to actually now start thinking of what you call the massive transfusion protocol, which involves giving fixed blood products in fixed ratios. So you have your packed cells, your platelets, and your FFPs. Unfortunately, in our situation, in our continent, most places, our blood banks, we don't have that luxury. But in the developed world, that's what they'll do. Because if they're having to give 4 units in an hour, then you activate. Usually you'd activate the lab and say, please, may I have the massive transfusion pack ready? And yeah.
Okay.
Thank you.
Thank you. Thank you. I think that's clear. Thank you. Sylvia Gendo asks what decision-making tools are available for the emergency department where the only monitoring tools are SpO2 and BP and basic vital signs. Dr. Chikophe, I'll throw that to you. So what decision-making tools are available in the ED when we just have the basic monitoring?
Okay, we'll go clinical because there's been lots of literature regarding use of capillary refill, both in pediatric and adult medicine. We're gonna use maybe level of consciousness, urinary output, because basically that's what our emergency department offers us. It's basically dependent on what you have, okay? Because most of our emergency rooms just have like basic equipment. And in the absence of those, then you use your blood pressure, your cap refill, urinary outputs, level of demarcation, the basic clinical parameters. That's what I would say. In fact, there's a paper I think written by Dr. Misango on hemodynamic monitoring for resource poor settings. It's on the resource page of the Critical Care Society of Kenya website. You can get more insight from that. Thank you.
Okay, so I'm guessing that for Sylvia, then with that basic monitoring, she'll be able to at least hold a patient in sort of in a steady state until she can get more help.
Definitely, because now, unless now they plan to get, a bit more of equipment, decision support can be very difficult, because you realize the more you start using these point of care devices, you realize clinical examination is good, but it never answers most of the questions, maybe up to 50%. So we need to augment that. Of course, the simple things like the passive leg raising test, but you need to have a continuous monitoring device that will detect sudden changes in your cardiac output or cardiac index. And these changes are very transient. You cannot do pulse pressure variation using a sphygmomanometer, for example. That would be, you understand? So you need a bit of investment. Yes.
Thank you. Yes. Thank you for that. That's nice and comprehensive. Nancy Kerubo is asking, in trauma patients, which fluid is preferred, normal saline or Ringer's lactate, given the hypochloremic acidosis associated with normal saline?
Who's answering that?
Whoever is feeling left out.
Kaiser can answer.
Remember from the slide that Dr. Chikophe talked about the pharmacokinetics and the pharmacodynamics of all the IV fluids in the setting of hypovolemia. At that point, whether you use your Ringers or your whatever is available, at that point where this patient is hypovolemic, you using a normal saline, the concern for the hypochloremic metabolic acidosis doesn't arise if you've not established euvolemia yet. However, it's sort of a balance, because as you go through the phases, you have your resuscitation, and then according to the phases, the rows, then that's when now you start thinking of how you're going to change, because the initial priorities getting them to a euvolemic state. So if you have, and this is a question that we get a lot, because of course, when the controversies around normal saline, which is not really normal, came about, people are like, oh my God, so I only have normal saline in my facility. So does that mean that I can't use it? You use it. But at that point, you want to establish euvolemia, then now you start thinking, after you've established your euvolemia, corrected your shock, then now you want to transition to a balanced fluid. Thank you, and over.
Thank you very much. I'm just running through the questions because they're still coming in. Dr. Chikophe, your presentation was very well received, and let's see how many we can go through. Kevin Umani asks, is esophageal Doppler a good tool in managing fluids? So I guess a good monitoring tool.
I think it's a very good tool, but it's quite advanced, and it needs a set of skills that you must have. And I know Umani is a cardiac anesthetist and probably uses it on a day-to-day basis. So you'll be able to measure your stroke volume in real time. You'll be able to maybe assess whether there's cardiac diastolic or systolic dysfunction. Yes, it is a very good tool, but the learning curve, and again, the level of investment. And I think for the sake of the audience, because we are talking about maybe standardizing the care that you're giving our patients, as in, we are not letting them to die. We are giving them like the kind of care that will make them survive, to get to be sorted out well, maybe, So I think the transesophageal Doppler is good, but it's it's advanced, and its application is probably limited to a few practitioners. But the thing that you're talking about, it may be applicable to quite a majority of the audience here. Thank you.
Thank you. That's well received. So Obonyo Henry, maybe I'll keep this with you, Dr. Chikophe. Kindly expound on the significance of perfusion index in monitoring in relation to today's topic, perfusion index.
So perfusion index is actually a plethysmographic variable. It's something you find on your modern day pulse oximeter. You remember the pulse oximeter actually measures the absorbance of various hemoglobin species, and it also measures the absorbance of both pulsatile and non-pulsatile components of blood in the tissues. So basically, this is the strength of it basically measures your pulsatile strength. It looks at the ratio of your pulsatile blood flow to the non-pulsatile blood flow. So when the ratio is low, for example, then this is maybe in a setting of vasoconstriction, or maybe a stenotic valvular lesion, or hypovolemia. Then you'll have a low perfusion index because your pulsatile component is certainly reduced in relation to your non-pulsatile. But in the setting of maybe a hyperdynamic circulation, like when the patient is septic or they have an AV malformation, thyrotoxicosis, and regurgitant valvular lesion, they tend to have a higher pulsatile component compared to the non-pulsatile. And actually, the variation of your perfusion index has actually been put into an algorithm called the plethysmography variability index, which is basically the same as your pulse pressure variation, only that this one is plethysmographically picked. The pulse pressure wave basically is through an arterial line, but the pulse oximeter probe is transcutaneous. So it is one and the same thing, only that, like I said, the PI or perfusion index is transcutaneous, as opposed to these other very dynamic indices like the pulse pressure variation, which is invasive. Thank you. And the perfusion index is actually very, very common in every modern day pulse oximeter. Thank you.
Thank you. Thank you. Sorry about that. Thank you. So maybe we'll get through 2 more questions. Farai is asking that we, if you could add your references so that the trainees can get sources easily. I'm sure you'll do that. And I can see that Brian Kariuki has linked Dr. Misango's paper in the chat box for those who want. Let me see. Morori asks if you can expound the importance of daily weight measurements in critically ill patients and fluid management.
So depending on where you practice, pediatric patients are the easiest to weigh on a day-to-day basis because you just leave them and you put them on the weighing scale. So like I said, if your admitting weight is 3 kilos as a baby, and then in a day, you're 3.3 kilos, that's 10% weight gain. The ICU is not a place where people gain weight. The ICU is a hypercatabolic state. So every time you see weight gain, it's most likely to be due to fluid retention, especially in the acute setting. So actually, positive or clinically significant positive fluid balance has been described as a net weight gain of like 10% from your admitting weight. And this is the one that has been associated with the adverse effects of too much fluid. So you find that they have pulmonary edema, gut edema, tissue edema, cardiac dysfunction. All these things tend to happen when your weight gain is above 10% from your baseline. So maybe it is time to maybe reinvest, maybe even buy new beds, like for the adult intensive care unit, the ones that can take weight. You just need to press a button and then give you weight, because that's the only way you can talk about positive fluid balance, because sometimes you may have an argument about insensible water losses, which is neither here nor there. But when you measure the weight on a day-to-day basis, I think it's more accurate in sort of trending the positive fluid balance. Thank you.
If I can just add on to that,
yes,
so
please.
it's positive fluid balances, or your weight gain of 10% has been associated with increased ventilator days, increased ICU stay, and higher mortality. We tend to use this a lot in pediatrics, even in the renal unit. They tend to weigh the patients every day. And it's a more objective way, even now for my pediatric colleagues, it's a more objective way of actually assessing your hydration status. Leave alone the one where you say skin tagger and what. You're able to actually tell from your percentage change in your body weight. That's more objective. Thank you. Over.
Thank you. We're running to a close already, but I don't know if either of you, any of you have sort of pet peeves or issues with rational IV fluid prescription in your day-to-day practice that sort of stands out, that you would say, every time Angela sends me a patient, this is what I find. Anything that stands out for you too as we close?
I think my comment about rational fluid use, now that we have tools, I would want to encourage, especially where people have the facility to be able to monitor fluid. There's a concept of fluid responsiveness, and that comes, in those phases, that graph that Idris projected, from your resuscitation into your optimization. When you realize that this patient is not fluid responsive, please start thinking of a vasopressor. And I want to say that adrenaline and dopamine can actually be given in peripheral lines. There are peripheral doses for them, so it is prudent to start even in the emergency department and not to pump them with too much fluid. Then you now get the concept of the Michelin man who has all puffy everywhere. But it's a learning curve. I think most people, and now that you have these fancy ways of predicting fluid responsiveness, it's not about just banging them with 500 mils of fluid. Even when you start with your 250 mils of fluid and you're able to use these tools to check for fluid responsiveness, you can be able to tell, and also monitoring the response to the fluid, because you may just need a 200 mils bolus as opposed to giving, traditionally we're taught just give 1 liter. Okay. Yeah, that's all I have to say. Over to you.
Okay, thank you. Dr. Chikophe doesn't want to answer. I'm sure he's boiling with it. Anyway, let me send this one to you. I'm joking. Let me send this to you. Someone is asking, Prof. Chokwe is asking, how does this concept of fluid optimization relate to our teams in Burns unit? Now that you wouldn't answer my question.
I was waiting for the lady to finish. Then
I see.
He's a gentleman.
Yeah, so Dr. Chokwe's question is difficult because in Burns units now, you may have that increased capillary